this is our third breast cancer seminar series. So thank you everyone who's returning and anyone new coming on. It's been a pleasure and we've learned a lot. I'm very excited to announce our speakers today, as these are my colleagues that I work very closely with. So I'll start with Dr. Kathryn Niemeyer. She is a breast radiologist and faculty at Indiana University School of Medicine. She completed her training mainly in the Midwest. She did her undergraduate training at the University of Michigan. And then she went to WashU School of Medicine. She did her radiology residency at Loyola and then her breast imaging fellowship at Indiana University. She has served on faculty at Indiana University and is currently the breast imaging fellowship director for the last 3 years. Katie has worked closely as part of the AMPATH partnership. AMPATH is a long-standing global health collaboration between Indiana University and Moi Teaching and Referral Hospital and Moi University in Eldoret, Kenya. And as part of that partnership, she's worked on a variety of different projects, including a breast POCUS initiative, a large breast cancer screening project, and other educational activities. And she works very closely with Dr. Loice Sitienei. Dr. Loice Sitienei is a consultant radiologist and lecturer at Moi University School of Medicine. She is also currently the chair of the Moi University School of Medicine Radiology and Imaging Department. She works in interventional radiology as a clinical practice, but also has a focus on breast imaging. She is the radiology lead on various large breast cancer grants, including the Breast POCUS grant, the Kenya-Nepal Oncology Project, a Gates POCUS grant. So she has been doing a lot of work in this space, and they are going to talk together today about the use of breast imaging in the United States and how it compares to Kenya and all of their experiences implementing breast imaging in Western Kenya. So Katie, Lois, welcome.
Thank you.
Thank you, Jenny. I will go ahead and share my screen. We're gonna try and do this together, so please bear with us as we present together from half a world away. So Dr. Sitienei and I met in Kenya and have worked together very closely. So we put this together hopefully to highlight the work we're doing and the collaboration it's going to take to make our breast imaging a little bit more similar between the US and Kenya. So we'll talk today about breast imaging for common breast complaints in the United States and Kenya. We will start by just going over some basic facts. 1 in 8 women in the United States will develop breast cancer. And in the United States, breast cancer is the second most common cancer in women. Over 240,000 women are diagnosed each year. Breast cancer in the US has a 90% survival rate. 66% of breast cancers are found in an early stage, and 67% of women have undergone screening mammography. 42,000 women die from breast cancer each year, and 1 person dies from breast cancer for every 6 people diagnosed per year.
So in Kenya, the case is almost reversed. Breast cancer accounts for about 25% of cancers in women, and about 1 in every 10 women will have gotten any form of breast screening. breast cancer is the second leading cause of cancer in Kenya, and it's the leading cancer with about 6,700 annual cases, and about 7 women die every day from breast cancer. The majority of breast cancer cases are already in stage 4 disease, and at around 37% when diagnosed, they're at stage 4, and an almost similar number or percentage is also at stage 3. So basically, they all come in at advanced stages. So when cancer is diagnosed at an early stage, as we might all be knowing, stage 1 and 2, it's almost virtually 100% curable, but in stage 3, as you can see, it's about 72%, and stage 4, the survival rate is at about 22%. So in Kenya, we are mostly at stage 4, where our survival rate is at around 22%.
So next we will go over basically an overview of breast imaging in the US and then in Kenya. So we can kind of compare what we are doing at both sites. So in the US, we have mammography, ultrasound, and MRI opportunities. For mammography, we screen all women annually, starting at age 40 for average risk women, and starting 10 years younger than the age of diagnosis of any first-degree relative, but not before the age of 25. And we'll get into more high-risk screening in a minute. And then we have diagnostic mammograms as well. One thing that everybody always seems to forget outside of the breast specialty world is the difference between screening and diagnostic. So most of our patients get screening exams where they get their 4 images and leave the department. The results are mailed or called, and there are no focal complaints. And then diagnostic mammograms are performed in women who either have a focal complaint, like a lump or focal pain or skin dimpling, nipple discharge, anything like that. They may have had an abnormality in a recent screening mammogram, or it may be done as a follow-up for a probably benign finding in another study. If they've not already had the 4 images at that time, those are performed if they're due, and then additional images with mammogram and ultrasound as needed are all performed the same day, and they get their results the same day. Just for anybody who's not as familiar, our standard 4-view mammogram includes bilateral craniocaudal views and bilateral MLO views. And the MLO views are 45-degree angle, not perpendicular to the CC view, but at a 45-degree angle, so we can better profile the upper outer quadrant, which is where the majority of breast cancers are, as well as get a view of the axilla. Just for those who haven't actually seen a mammogram done, here is an image of somebody getting a craniocaudal view performed. You can see the detector is here at the bottom. The breast is in compression and the beam comes from above, and this is the associated image. And then the MLO view, you can see the angle and how it's going up into the armpit. Again, the compression and the image that is provided. One of the biggest complaints we get from our patients is compression. Nobody likes it, but it is actually very important. Compression separates the glandular tissue. It decreases superimposition of tissue. It allows us to use a lower dose, which decreases scatter radiation and decreases dose. But even more importantly for my day-to-day, it improves resolution and contrast of the image so we can actually see microcalcifications and other pathology. We have 4 different categories of density, ranging from predominantly fatty, scattered, heterogeneously dense, and extremely dense. And as you all probably mostly know, as you go up in density, you go down in sensitivity for mammography. So because of this, we have been working on other things to help with our screening of women, mostly for women with dense breasts. We pretty much universally across the country, at least at all our Indiana sites and at any site I've ever worked anymore, we do 3D imaging or tomosynthesis, same breast positioning, standard compression. We use it for both 2D and 3D. We use it for screening and diagnostic imaging as necessary. But basically the tube acquires images at several angles, and then reconstruction, the images into slices that are thin and high resolution. The advantages are they remove challenges from overlapping tissue, they increase margin visibility, they improve localization of findings within the breast, and they overall increase our breast cancer detection and decrease our false positives. It seems the data is suggesting that the biggest help anymore is the decreased false positive rate. I would say that as a relatively new breast imager, not so much anymore. I was still raised in the era of tomosynthesis, and the younger radiologists probably wouldn't know how to read a 2D mammogram anymore. But this is a case just to highlight the advantages of the 2D imaging versus the 3D imaging. Here on the left, you have a mammogram, and there's a little island of tissue here that looks denser. If this was a baseline mammogram, you may say, oh yeah, maybe that looks dense enough to call back, but maybe not, and depending on the rest of her breasts. But then you get into her 3D images, and in this slice, you can see buried in that tissue is an actually spiculated mass. You can see the spiculations coming out from the mass, and you're going to have a lot more confidence in calling that patient back, that you are calling something that the patient will actually need a biopsy for and need worked up. Ultrasound, we do both as a screen and a diagnostic tool. It's becoming less utilized as a screening tool, but we still do use it for average risk women with dense breasts. Ultrasound uses sound waves to create images. The advantage is there's no radiation, there's no compression, and we can detect blood flow. We can also look more closely at the axilla. So for screening breast ultrasound, MRI seems to be overtaking screening. It's becoming the more utilized tool. It's showing a higher breast cancer detection rate, and it's what the ACR now recommends. So we really use our ultrasound as sparingly as we can, mostly for women who can't get MRI, or who really don't want MRI. But we do use it as a supplemental screening tool for average risk women with dense breasts. It can be done as a handheld exam or an automated exam. Here on the right is a device that we have here at IU. It's an automated device that decreases the amount of time the radiologist has to spend in the room with the patient and allows us to do more exams throughout our clinic day. Diagnostic ultrasound, we use it for clinical abnormality, lumps, focal pain, nipple discharge. We use it first line in anybody under 30 as an adjunct to mammo in patients over 30. Obviously, if pregnant women with palpable abnormality, we use ultrasound a little bit more, but they can get mammo. We use ultrasound for persistent mammographic abnormality. This can help determine solid versus cystic components. I think this is the best way to guide percutaneous biopsies. It's the most comfortable for the patient, and I think the easiest and most direct way to get to a finding. We can evaluate the breast and axillary lymph nodes and the morphology of the lymph nodes rather than just size. And here are some images from screening ultrasound here. This is our ABIS images that we get. They're kind of cool. You get these coronal views and then transverse views down here. It's thousands of images to look at, but they can be kind of cool images. Here's a nice image of a benign cyst. Okay. And then here is a more suspicious mass which is hypoechoic, almost isoechoic with angular margins and some posterior shadowing. And then finally, we use MRI for both screening and diagnostic purposes. Of note, MRI to evaluate for breast cancer absolutely has to have contrast. It's multiphasic in a full protocol MRI. Non-contrast MRI cannot diagnose breast cancer. You can use it only for implant evaluation, which we don't really use in Kenya, so we're not going to talk about much, but this is an example of a little finding. This area looks relatively innocuous here on the pre-contrast images, but once you add contrast, you can see right there's an enhancing heterogeneous irregular mass in that area of the breast that you would never see on the pre-contrast images. This correlates with one of the articles that we sent out. So high-risk screening is one of the big hot topics in the US when it comes to breast cancer screening. It seems like we're getting more and more genes every day for those who don't do high-risk screening. That's how I feel. But obviously the two big ones are the BRCA mutations 1 and 2. We treat BRCA carriers the same way as we treat untested first-degree relatives of a BRCA carrier. As you know, some people don't want to get genetic testing for insurance purposes or fear or lots of other reasons. So if they don't want to get tested and they have a first-degree relative with the BRCA gene, we'll treat them the same. So historically, we've recommended starting MRI at age 25, mammo if MRI is unavailable. And then historically, we would start mammo at age 30, but it seems like the recommendations are pushing for later mammo in these patients and continue with the MRI as long as they're doing MRI. So the official ACR recommendations now recommend MRI at age 40 rather than 30. Estimated lifetime risk of greater than 20 to 25%. I typically use 20% based on family history and other factors. I won't get into all of the different risk calculators. But we start mammo at age 40 unless a first degree relative was diagnosed earlier, then start 10 years before the age of diagnosis, but not before 25. The updated ACR recommendations recommend MRI at age 30. And there we are recommending earlier risk assessment, so that's becoming more of an option. Radiation to the chest between age 10 and 30 years old. The new ACR recommendation is to include abdominal radiation that may overlap the breast. The mammogram should be performed 8 years after radiation or after the age of 25, whichever is later. And then numerous other syndromes, Li-Fraumeni, P53, they get every cancer under the sun, Cowden syndrome, benign Riley-Ruvalcaba syndromes, and then as well as their untested first-degree relatives. And if you look at the article, there are more and more genes that continue to be added, ATM, CHEK2, NF1. We are continuing to add those. And then breast MRI, we also use for diagnostic purposes to evaluate for extent of disease. In new cancer diagnosis, we look for cancer in patients with axillary lymph nodes that were positive, looking for an acute occult primary. And then we also look to evaluate for response to neoadjuvant chemotherapy, as well as for problem-solving purposes, like in nipple discharge with negative imaging and things like that. We do image-guided breast biopsy with all of our modalities, ultrasound-guided, stereotactic biopsy, and MRI-guided biopsy. So we have the option of biopsy almost anything we find on imaging. And so I will turn it over to Lois about what we're doing in Kenya.
Okay, so in Kenya, our mainstay of screening is a clinical breast examination, which is not recommended in the US, but that's the most common screening tool that we have in Kenya. Mammography is, yes, recommended, but the machines, we don't have enough machines or distributed throughout the country. So at the hospital which I work, which is Moi Teaching and Referral Hospital, is the second largest hospital in the country, and it's a referral facility. Our mammo unit is not working, and similar to facilities in the western part of Kenya, except for one hospital. So most of our patients cannot get mammography services, except in the private hospitals. So the country has about 47 what we call counties. Those are like subdivisions of the entire country. Each county has a machine, but we can't really tell how many are working at the moment. So we use ultrasound for early detection. Our guidelines actually categorically say ultrasound is not for screening, but we use it for for detection. And currently we are using POCUS, which is being studied and also being introduced into the public sector. But as I have said, it's not really for screening, but for early detection. It's also used mainly in diagnosis. So any lady who presents with any breast complaints will get an ultrasound. MTRH has an MRI unit that was newly installed in October of last year. So we are starting to have a few breast MRIs, and mostly these are used for determination of extent of disease or for diagnostic purposes.
So you can see we have some differences in what we're doing. So in the United States, breast imaging is very standardized. We are heavily regulated. We are regulated by both the FDA and the MQSA. There are strict markers for radiation doses, quality of images, training of radiologists and technologists, and much more. There are daily, weekly, and monthly checks for our image acquisition equipment and our reading stations to make sure that we have the appropriate contrast and resolution, and we can see all the things that we're looking at.
So in Kenya, we don't have a truly nationwide breast cancer screening program, as earlier alluded to. So we have no clear standards that are in place of how the mammograms are read and any, regulations regarding that.
So this is just for anybody who doesn't know the 7 BI-RADS categories that we use. We have a BI-RADS 0 for, hey, we're not done yet. BI-RADS 1 and 2 for normal or negative, BI-RADS 3 for follow-up, and 4 and 5 for, hey, we need a biopsy, and BI-RADS 6 for a known cancer. And all of this is very standardized. And if you put, say, certain words in the body of the report, you know what you're going to put for your BI-RADS assessment. And based on your BI-RADS, you know what the recommendation is going to be. And then we have our condensed BI-RADS. That is the other paper that you have received. So one way we're trying to make, or we as a general breast doctor population, one way they're trying to make BI-RADS more universally used in more breast cancer screening and imaging more acceptable is to condense the BI-RADS down, because it can be relatively complicated. So rather than, the 40 descriptors that I use on a daily basis, we simplified it to finding type, normal, cyst, lymph node, or mass or distortion. And then if it's a mass or distortion, what's the shape? Is it round or oval, or is it irregular? Are the margins circumscribed or not? Is the echogenicity hyperechoic or not hyperechoic? And then the recommendation falls into clinical, imaging, or biopsy. So just a way to try to simplify BI-RADS to utilize better in the international setting. So one thing that really shocked me when I went to Kenya was the difference in how we're reading things. And looking back, maybe I shouldn't have been shocked, but when I'm looking at breast imaging, you can see the images on the left. The image on the left side of the screen is a picture of my workstation. I have the highest resolution monitor in the hospital on the left where the images are. And then I have extra monitors to do my reports and all of that. And I can zoom in on the monitor. I can zoom in to, a small micro component of that screen to look at images as closely as I want. And this is what makes digital acquisition better than screen film. At baseline, it actually has worse, digital acquisition actually has worse contrast and resolution than screen film acquisition. And then I'll let Lois talk about Kenya.
So in Kenya, I'll talk specifically about my hospital, and which is replicated in the other county hospitals, which are public facilities. We use what you can see there, a screen. We get our images on a digital mammography unit, but print it on film, and then I come and read it on such kind of a viewer. So I'll have the standard 4 images, and at that point, I don't have the added advantage of zooming in, zooming out, and all that. I don't have the advantage of having magnification views and other additional views at that point. So I'll just have the standard 4 images to look at on a viewer, on a screen, on a printed out image.
So our quality is a little bit different. Oh, and that's just an example of being able to zoom up there for you. Forgot to get rid of that animation. So now we have a 40-year-old with no complaints. In the United States, we would have this 40-year-old just come in and get a screening mammogram. This would be performed yearly and covered by insurance by law. with no copay.
And in Kenya, well, we have the regulations written somewhere, but it's not practiced. So usually any female 40 years and above would not get any imaging unless they have a complaint. So no complaint. We at best would do a clinical breast exam if they come to the facility.
And here's just an example of a screening mammogram below, because I'm a radiologist. Dr. Sitienei is a radiologist. We like pictures. We're going to use these clinical scenarios just to highlight some of the additional things that we've encountered differently. So screening mammography in the US recommended by all breast specialty organizations should start at age 40, which we always say is proven to save the most lives, with a almost 40% reduction in breast cancer deaths since mammography screening became widespread in US in 1990. And I wanted to leave this slide in here. I won't go into detail, but I wanted to not just spout about how mammography is so great, because it is great. We do know it saves lives, but there are also risks. There's a lot of anxiety. There's overdiagnosis with DCIS. There is a small amount of radiation. So we try to minimize the risks and increase our benefits as much as we can. And there is definitely the benefit of earlier stage with better prognosis. And this is just a slide to show that all breast specialty organizations recommend starting screening at age 40. American Cancer Society is a little bit in the middle, or was. And then most of them recommend every year. And we pretty much are doing TOMO throughout the country. And a big win, USPSTF used to say start at 50, and we have now convinced them, after lots of work in Washington, not by me, by other people, to start at 40. And at IU Breast Imaging, we recommend annual screening beginning at age 40 to all of our patients.
Well, in Kenya, again, as you've heard, we do a lot of clinical breast exams. So for the age of 25 to 34, we do clinical breast exam every 3 years, and that's by either a nurse. We have a cadre called clinical officers. I think what would be like a physician assistant in your setup. And then we have, rarely do they get the doctors themselves to get to see these patients, but yes, if they get to see, they would do a clinical breast exam. Then 35 to 39, they get a clinical breast exam and ultrasound every 2 years. Above 40 to 55, they get clinical breast exam and mammogram every year. And after 56 to 74, they get CB and mammography every 2 years. After that, then you discuss with the patient what is their desire for screening at that point. So it's quite different.
So we now have a 45-year-old woman with dense breasts. And this patient in the United States would get their screening mammogram first, and that's how they would find out they have dense breasts. We would recommend yearly mammogram. Again, it would be covered by insurance. And then we'd also offer supplemental screening with breast MRI or whole breast ultrasound if they cannot get an MRI.
So in Kenya, most likely the patient will not have had any mammogram in the first place. And if they're lucky, they could have had a clinical breast exam done by any of the cadres. And there would be no other supplemental imaging at that point, but it can be recommended by a clinician and tell them that, yeah, you're above 40, you should get a you should get a mammogram. But that's as far as it goes.
And then similarly for patients who are high risk for breast cancer, we've discussed the new ACR recommendations. These patients are getting screened early in life at age 25, especially women who are Black, have Ashkenazi Jewish descent or family history, and really pretty much any minority. The ACR now recommends risk assessment at age 25.
So in Kenya, we still don't have a screening program nationwide. So we are working on that. We are trying to sensitize. So it's work in progress for us, but we have a lot of barriers. For example, I come from a tribe called Kalenjin, And among the Kalenjins, they believe that you don't go looking out for trouble. So you don't go screening so that you find something. So you wait for it to happen, then you can get treated. So we still have a lot of cultural stigma. We have difficulties establishing family histories because we don't have a standard way of keeping records in the hospital, and most of our records are on paper, so you may not be able to establish some of these histories.
So our next case, we have a patient who had calcifications on mammogram. So suspicious calcifications are small. Big chunky calcifications, which are easier to see, are generally benign. So our small concerning calcifications are sometimes barely seen even on our high resolution monitors. And in order to look at these with our magnification views, specialized paddles are utilized to perform the magnification views so that we can blow up the picture and really try and see these calcifications. A lot of times with magnification views, you see more than you saw in the original pictures.
So for us, suspicious calcifications may be difficult to see the way we are reading them on a viewer. And I had a patient a few weeks ago who had a mammogram done prior. We missed the calcifications. This time she came back, she had a palpable mass. And when we reviewed the previous images she had, there was actually calcification. And even with a function, when functional, the mammo units may not have the equipment to perform magnification views or other additional views.
So again, we're radiologists, we like pictures. So you can see this is an example of magnification views. There's segmental fine pleomorphic calcifications that, I can't get this one to go, that are kind of marching towards the nipple. And so we would recommend a biopsy based on the imaging appearance of these calcifications. And we call it a BI-RADS 4. And for those who know A, B, and C, a BI-RADS 4C, highly suspicious for calcifications. So we would then take the patient, schedule them for a stereotactic biopsy, which would be performed. And if we were unable to perform the stereotactic biopsy, they're too close to the skin or weird location or something like that, we could perform a mammographically guided wire or wireless localization for surgical excision.
So in Kenya, we don't have stereotactic biopsies in most public hospitals. And currently we have it available at the capital city, which is Nairobi. Nairobi is about 300 kilometers or about 200 miles from where I am. So the patient would have, if we diagnosed it in Eldoret, where I am, the patient would have to go to Nairobi for that procedure. That's an 8-hour drive. And considering the financial constraints, they may not be able to do that. So what sometimes we do is to try and locate that on ultrasound and then biopsy on multiple, like multiple sites in that quadrant to try and see whether we'll get any of those calcifications.
So here are just some images of how we perform stereotactic or mammo-guided biopsies. We have prone tables here on the left, upright tables, and then a picture of the biopsy device, and then images from our biopsy. And you can see it's a little different when you can put your needle right in at the calcifications and just leave off a little piece with the calcifications in it. You're gonna have a lot more accuracy. So next we'll talk about a female with a palpable lump. In the United States, if the patient is over 30, she would start with a bilateral diagnostic mammogram and then get a targeted ultrasound. This patient is more likely to have less dense breast tissue and more likely to have something given the age is older. So we always start with mammogram. Under 30, we expect it to be a higher likelihood of benignity, and also the patient will likely have more dense breast tissue, making mammogram less sensitive. So we start with ultrasound.
So we do a clinical breast exam for all our patients, and then this would be followed by a breast ultrasound. If mammogram is available and the patient is above 40, they would go ahead and get a mammogram. And mammograms are available in the private facilities at a paid, they pay for that service.
I'll let Lois talk about this case.
Okay, so this on the left side of the screen, we have the breast mammogram. We can see a radiodense lesion that is there. And I think I prefer talking about the ultrasounds more, which I see here frequently. There is an irregular hypoechoic mass that appears to be infiltrating the adjacent tissues. It has this very markedly hypoechoic lesion with a nicogenic peripheral region, and it is crossing all the tissue planes. And at the far right end of the image, we have a pathological lymph node that has a thick cortex. So this is a lesion that we would biopsy. Highly suspicious BIRADS.
Yes, and I just included a normal lymph node here just to highlight that we don't care about size in mammo for lymph nodes. We care about morphology, and this has thickened cortex, which is nodularly thickened, or focally thickened, which is more suspicious than diffusely thickened. It's got vascularity to it. I'd put money on this having that this would be a positive, having metastatic breast cancer cells in it, whereas this is a nice normal lymph node over here. I wouldn't put money on an actual biopsy, but if I would, I'd bet this was going to be positive. And like Lois said, this is BIRADS 5, highly suspicious.
So we would do an ultrasound guided biopsy. And as you can see on the image on the left of the screen, you have the needle going through the mass, and we take our course from there. And on the other side of the screen is how I believe that is Katie doing an ultrasound guided biopsy.
I think that's one of our residents. I don't have such a nice watch, but and I stand on the other side of the table because I like my neck. But yeah, I think this is one of the biggest advantages we are doing with our POCUS study that we did, is that more biopsies are getting done with ultrasound guidance rather than palpation guidance, which is going to really improve our false negative rates. So now we have a patient who is 28, so we all start with ultrasound.
And in this image, we see a well-defined mass. There is hypoechoic. This has some intralesional vascularity and some peripheral vascularity. This patient is a patient we would like to follow up every 6 months because we would think this is a BIRADS 3 case. And we would follow up that patient every 6 months for the next 2 years. And it's probably benign. In my setup, we would most likely tell the patient it's most likely a fibroadenoma.
Exactly. And we can always do a biopsy if the patient is high risk or circumstances limit the ability for follow-up. In either country, if the patient can't get back to the hospital easily or may lose their insurance, or, who knows, biopsy is always appropriate. Maybe they're just too type A and they can't handle not knowing, and growth at any point during follow-up warrants biopsy. Okay. I thought I got rid of all our animations, but apparently I missed some. So just to sum up our female with a lump, because this is our most common situation, and this first patient got a biopsy. When we have in the US, we have strict guidelines for interpretation and follow-up. So, we have rules for why we would follow up that fibroadenoma. We know it's less than 2% chance of malignancy. Any funny margins or anything, we biopsy. But again, all following guidelines that are very well set up. And then our biopsy results are closely monitored and patient notification is regulated. So if we aren't notifying our patients, if they're not getting letters, we get dinged by the FDA and we may not continue to have our breast center. Breast specialty pathologists are usually available to read our pathology. We always perform RADPath concordance on our biopsy results to make sure that the pathology matches what we saw in imaging, to reduce our false negative rate. And then immunohistochemistry is done standard on all of our biopsies.
So here in Kenya, we are still working on doing all the biopsies under image guidance or under ultrasound guidance. We still find facilities that do blind or palpation-guided biopsies, and you may not find the RAD path concordance being done in most of our facilities. It's something we're also working on to always compare what we had before and what the pathologist found. We also frequently have delays in pathology getting the results because one, we don't have specialized pathologists who are breast pathologists, so we share the pathologists with every other department. So you find like in our facility, you might have like 4 or 5 pathologists serving the entire hospital. So your sample may sit there for, generally takes about 21 working days to get the results back and sometimes up to a month. And then the immunohistochemistries are not always done upfront. So if the results come back positive for malignancy, then you go ahead and then request, and the patient has to pay for that service an additional fee. So in our in the setup where there is a financial constraints, then you find some patients may not be able to top up that fee to get the immunos.
And I was going to say, since Dr. Sitienei mentioned the 21 to 30 days, in the US, I tell my patients to expect a 5-day turnaround. And honestly, most of our results come back the next day or a couple days later. And in both countries, I think biopsies and follow-up exams are expensive and can be a financial hardship for patients. So something we always try and consider. And patients are lost to follow-up or late to follow-up very frequently in both countries. Next, we have our clinical scenario of a 42-year-old with nipple discharge. In the United States, if the patient is over 30, again, bilateral diagnostic mammogram and targeted ultrasound, and under 30, targeted ultrasound.
In Kenya, they would get a clinical breast exam and an ultrasound. If mammography services are available, then they would also get a mammogram. Then most of these patients also go ahead and get a cytology of the discharge. And for the ones that have seen from practice, most of them come back negative, the cytology results, but I don't have any publications to that.
Yeah, I've never done a cytology of a nipple discharge, and I don't know if the surgeons do in their office, but we did do a brief literature search, and it didn't look like it had very good predictive value. Just briefly, when we talk about nipple discharge, when the patients have benign characteristic nipple discharge, bilateral milky, milk tinged, yellow, green, and it's expressed, it's usually physiologic, and we don't typically do ultrasound. We reserve our ultrasound most typically for patients who have pathologic features or discharges bloody or serous. It's single duct, it's spontaneous, much more likely to be related to the breast, more often a papilloma, but it can be cancer. And then we have some images here. We have a patient who had nipple discharge, and she had a bilateral mammogram. You can see she has very dense breast tissue. We couldn't see anything on the mammogram, but when we did the subareolar ultrasound, you can see that there is a small duct there. It's not really even dilated, but when you look closely in the duct, you can see that it's not just black fluid, but there's some grayscale tissue or something in there. And when you put flow on there, you can see that there actually is some blood flow to that. And that was an intraductal mass. And that was a papilloma with DCIS in it. We still typically recommend biopsy of most intraductal masses. If the patient is symptomatic, I always recommend biopsy of the intraductal mass. Although we are every year seeming to decrease our aggressiveness with our papillomas. So to sum up, our 42-year-old with nipple discharge, this is most commonly due to papilloma, and biopsy is performed if seen on imaging. Patients are referred to breast surgery after biopsy if underlying abnormality is identified, and sometimes nipple discharge resolves with the biopsy.
So if the breast ultrasound is done and a mass is seen, we would go ahead and have a biopsy done. If the ultrasound is negative, the patient gets a surgical review. And if there was anything that was seen, they still get a surgical review as well. And for possible symptom management and possible duct excision. The breast surgeons are becoming more in the country. We are having more breast surgeons currently, so at least we can get the surgical services in the country.
And we also use ductal excision and MRI quite frequently for these patients when their imaging otherwise is negative. All right, so breast pain is one of our favorites because it is very common. It's often not an indicator of cancer. And we'll talk a little bit more about it on the next slide. So we try to avoid doing what we can when we can.
All our patients with breast pain would always get breast ultrasound. And if the patient is above 40 years old, I will always recommend a mammogram to be done because it's like an opportunity to explain to the patient why they need to get their mammogram. But it's not really like a recommendation somewhere in the hospital protocols.
But it gets them in the door. So Dr. Sitienei and I both love this slide because this is what she remembered of my lecture the first time I gave it. So breast pain is very common and often physiologic. If it's diffuse, cyclical, not related to any more concerning abnormalities like a lump or skin or nipple changes, we pretty much try to do nothing. If it's unilateral focal persistent pain, we may work it up. So diffuse pain, if the patient is over 40 and up to date on her annual mammogram, we don't do anything other than if she hasn't had her mammogram, she can get it. Under 40, we try to do nothing, reassure the patient, talk about decreased caffeine intake, salt, alcohol, vitamin B or E, and where appropriate, fitting bras, primrose oil, all that. I always joke with patients that I can only suggest they decrease their caffeine intake because I won't give up my coffee because I like my coffee. I'll deal with the pain. If the pain is focal or persistent and they're over 30 in the US or over 40 in Kenya, then they get a diagnostic mammogram with possible ultrasound, or in Kenya, more likely ultrasound than maybe a mammogram. And under 30 or under 40 in the US, we start with ultrasound. So here we have just some images to start. Our next clinical scenario is breast swelling or erythema. And when I use this slide in my medical student lecture, this is the one thing the med students all get right is that poda orange appearance on the skin there, and a little erythema on the right. So in the United States, if you have swelling or erythema in the breast, this is often treated clinically with antibiotics and then only sent to breast imaging if concern for abscess or it's not resolved after appropriate antibiotic therapy. But I do see patients before they get antibiotics. We use mammogram and ultrasound as per all the prior cases we discussed.
So they also get antibiotics and we review them within a month, ideally, but most of our patients, we lose them to follow up. They may never come back to the facility. So normally we still do a skin punch biopsy in the same sitting, and so that we are able to call them back and tell them your results came back. And if it's something suspicious, then we can call them back to the unit.
So just again, radiology, we have to have some pictures. You can see on the right breast here, she has some skin thickening, right axillary lymphadenopathy and trabecular thickening. You can see the skin thickening better on the CC view, and trabecular thickening is one of those things we all know it means edema, but I think people don't always understand what it means on the mammogram. I think the best way to describe it on the mammogram is all the little lines, especially in the subcutaneous fat, look thicker on the right than on the left, and that's because of all the fluid interdigitating between fat lobules. I'm not going to go into this too much because I think you all know, but Obviously, when we see edema, we're thinking of two main things, infection and inflammatory, and I'm talking about unilateral edema. Infection is common, painful erythematous breast, more common in patients who are breastfeeding, diabetic, or smokers, trial antibiotics, but confirmation of complete resolution is a must because we never want to miss inflammatory breast cancer, which is a clinical diagnosis and does not typically, in our case, require a skin punch biopsy. If we see the underlying image, we can underlying cancer and we can biopsy that, prove the cancer, and then clinically diagnose the inflammatory cancer. We don't have to do a skin punch. We use skin punch more commonly when we can't find the underlying cancer. And in this case, this was a case of inflammatory breast cancer, and this was a case on the right of mastitis. And you can see that in this case of mastitis, the patient also has skin and trabecular thickening. This is a case of an abscess, which I think I included because I think you can see more focally the trabecular thickening around the abscess, all that edema surrounding the abscess, less so the skin thickening. And then I'll let Lois talk about the next couple of slides.
So this is a patient with an abscess, and the way it has angular margins, it's hypoechoic. And when you compress using your probe on ultrasound, you would see the movement of the fluid within. Okay.
Oops, sorry. I hit it. Go ahead.
All right. So when we find an abscess, we'd actually do an aspiration in the same sitting. When we are still with the patient there, we do ultrasound guided. It's painful, so we pre-medicate the patient. Normally in our setup, they would just we would give them a morphine injection, give them an antispasmodic, that's Buscopan, and ondansetron to just help them not to, an antiemetic ondansetron. And we'd go ahead and just do the aspiration in that sitting and then allow them hormone antibiotics and analgesics.
They're much nicer than we are. We just give lidocaine and I tell them not to smoke. So our next scenario is a pregnant woman with a lump, and we both do ultrasound.
Yep.
So here on ultrasound, this is an example of a pregnancy-related finding. We have a patient with a galactocele, which is a benign retention cyst containing milk. It's usually a circumscribed mass, and it may have low-level internal echoes or fluid debris levels. Here you can see that there's almost a solid component, but we just felt like that was tissue kind of floating in that. And we actually then did a mammogram, which is not always available in the US because this patient was breastfeeding, not pregnant. And here's an example of the classic fluid fat level that you see. And here that mass was fat containing. So being fat containing on mammogram is diagnostic. And pregnancy and lactation related findings, lactational changes cause increased density on mammo, making it less sensitive. We also see lactating adenomas, galactocele, mastitis, and abscess, and increased or rapid growth of fibroadenomas and breast cancer. So in the United States, most of the time masses in pregnant women are benign, but if we are unable to determine, biopsy may be warranted. There can be some delay in diagnosis given the high benignity of the number of masses, but we typically get them sent to us pretty quickly because people are aware of pregnancy-associated breast cancer, and this is usually identified and treated with a multidisciplinary approach.
So ultrasound is a mainstay of imaging, and we do a biopsy if the lesion is suspicious. But from my experience around here, most women who have lumps in pregnancy, they tend to overlook that and they don't seek care and they hope it will resolve by the time they deliver or as they're breastfeeding. So they don't come for any form of imaging.
So here we have our last clinical scenario, a patient with an itchy nipple. And just like before, we start with mammogram and then ultrasound and MRI if negative. In Kenya, they often go straight to the skin bunch biopsy and then do ultrasound and possible mammogram if over 40. Just want to get to the end because we're running out of time. On mammogram here, there's a tiny little subareolar spiculated mass that you can barely see on ultrasound. On MRI, there's asymmetric enhancement of the right nipple. Paget's disease is the diagnosis in this case, and that's cancer involving the NAC. Main differential is eczema. If there's underlying cancer, we can biopsy it. If not, skin punch biopsy is available. And here's just pictures of eczema versus on the right versus Paget's on the left. Apparently we made it all. So in the United States, they get a full workup with mammogram and ultrasound if performed. If underlying cancer is identified, biopsy is performed. If no underlying cancer is identified, surgical consultation is recommended. MRI and or skin punch biopsy can be performed.
Normally, these patients rarely come to radiology. They go to the surgeons and they normally get a skin punch. If they're sent to radiology, they get an ultrasound. And we see something, we actually do a biopsy as well.
So to sum up what we had discussed, breast cancer screening has changed the way we treat breast cancer in high-income countries.
And the low and middle income countries struggle with access to mammography and appropriate utilization of technology when available.
And breast ultrasound is a much more widely available tool, but it's still not as utilized in Kenya.
Early detection with CBE and ultrasound is a good place to start to build our breast cancer detection program in Kenya.
With expansion of detection capabilities, biopsy and minimally invasive treatment options must continue to grow together. So as we move forward with screening programs in Kenya, we need to move forward with biopsy modalities and less invasive treatments. So just for an example, if you find DCS on a mammogram, you must be able to biopsy the calcifications. You must have well-trained pathologists. You must be able to localize them for surgery. You must have a surgeon capable of performing the less invasive surgery. You must have radiation capabilities for appropriate treatment if they can get a lumpectomy rather than mastectomy. You must be able to continue screening the breast if breast conservation is being performed. And I'm sure I left things out of that list.
The technological advancement must be done in conjunction with not only our surgeons, the pathologists, the oncologists, but also the government officials and hospital administrators. And most importantly, we must work to educate our women and their spouses, because this is a very patriarchal society in the African setup, and the men make a lot of decisions on behalf of the women. We must also address cultural stigmas, and we must learn to improve women's health in a patriarchal society.
And then we have 3 real life scenarios just to sum up kind of what we're dealing with and what our goals are.
So this is more what I see more frequently than not, patients who present with late stage disease. This is a fungating mass ulcer. You can see the ulcer there. The patient has supraclavicular lymph nodes, axillary lymph nodes. This patient had metastatic disease at diagnosis. These are images from our point of care ultrasounds that we've been rolling out in the last almost 2 years.
And we've biopsied these, but we do not have pathology, I believe. And this is a case, this is a case I did yesterday, and this patient has a tiny little area of calcifications in the subareolar breast. We did a stereotactic biopsy, and she has DCIS with microinvasion. A clip was placed, and then a Savvy Scout was placed, and she will get her surgery soon. And given the proximity of the nipple, if this progressed, the nipple would probably be involved rather quickly, but we found it early. So thank you all for listening, and we're happy to answer some questions.
Well, good morning. My name is Todd Tuttle. I'm a surgical oncologist at the University of Minnesota, and I'm partnering with Dr. Morgan. I want to thank you both for a wonderful presentation. It was very unique. I didn't know what to expect, and I really liked the back and forth. It was a great contrast between what's happening in the United States and in LMICs. I want to go through a few questions that came through. First of all, Lois, someone asked why is CBE recommended as a screening mechanism, but not ultrasound in LMICs?
This is mostly because of lack of staff. So like in Kenya, we have about 285 radiologists compared to a population of about 50 million people. So we have very few specialized staff. Then ultrasounds, we have a category of staff sonographers who do ultrasounds, and they may not be in every facility. And lastly, the facilities that are there don't have imaging units. So you may find a level 1, 2, or 3 hospital that doesn't have an ultrasound, it doesn't have a mammogram. I mean, a national referral facility, it has one mammography unit that is not functional. So it's just about the availability of the technology and the staff. So clinical breast exam is better than nothing, I think is the idea.
Mhm.
Thank you. Another person asked, what's more precise for determining tumor size, ultrasound or mammography?
I generally think ultrasound is a little bit better, but it's variable depending on the mass. There are invasive lobular carcinomas that you think are not that big. You can't really see them very well in mammogram. You can't really see them very well in ultrasound, and then the MRI lights up. There are masses where the mass becomes a little bit infiltrative, and you can see it a little bit better in a fatty breast on mammogram. But in general, I think ultrasound tends to be a little bit more precise.
We have a question in the Q&A part of the Zoom. How do you approach a 60-year-old with bilateral nipple retraction, often on breast pain, BI-RADS2 and mammogram and ultrasound?
If it truly is new nipple retraction and it's worsening and you don't really have a reason for it, I think an MRI is a reasonable next step in the US.
Lois, any comments about how that might be approached in Kenya?
We would do an ultrasound, and if we still don't see anything, we may still biopsy the region retroareola and try and see whether we can find anything.
Thank you. I wanted to bring up this case because what we're trying, Dr. Morgan and I are trying to do is set up a breast cancer forum through this seminar series where cases like that can be sent out to everybody and we can all comment about how we would manage, a triple negative breast cancer in Kenya or stage 4 cancer in Honduras. It's going to take a little work to get that done, but I think that might be pretty effective. Also, a good way to kind of connect us all.
Yeah, that's great.
Well, I want to thank you all for that's a lot of work putting that together. You did a phenomenal job. It was also very entertaining. I loved how you do it.
Thank you.
Take this on the road. I just want to one announcement before we go. Our next breast cancer seminar is going to be August 5th, again, a Tuesday. We have two speakers, Dr. Casas Chavari from Rwanda. She just started a breast fellowship at Rwanda, is going to be talking about the surgical treatment of breast cancer, specifically mastectomy and breast conserving surgery. And Dr. Umar Chowdhury is a plastic surgeon at the University of Minnesota who's been quite active with our breast cancer fellowship at the University of Minnesota and has done a lot with global breast cancer. So that's August 5th. Let your colleagues know. It'll be great. I cannot promise that it'll be as good as this one, though.
I expect it to be even better.
Thank you.
You.
Wonderful. Thanks, everybody, for participating.
Thank you. Bye-bye.